Hello, and today we're going to look at Chapter 31, The Infant and the Family. So, when we're looking at the growth and development of an infant, in the office visits, what we're really looking at is the height and the weight in the head circumference. This is how the growth of an infant is tracked and is determined whether the infant is on track or whether they're falling behind. And you can see here all of the various stages that the infant's going to reach at 6 months and at 1 year and along the way. And just keep in mind that just like we talked about in the development lecture, that the growth happens in spurts. It doesn't happen sequentially. So we're going to see spurts of growth here and there. And when we talked about the newborns a couple weeks ago, we talked about how immature their systems are when they're first born. And you can see here what happens as the systems mature. So, as we talked about last time, the growth and development of the gross and fine motor skills. The fine motor skills develop after the gross motor skills. But we can see some of those fine motor skills develop along the way. So we're going to see an infant reach for an object before they grasp an object. And that's going to be the grossest of reaching, and the grasping is that fine motor skill. There's a great table on page 823. It's table 31.1 that outlines all of the different development of the motor skills. If you take a look at this picture here, we have a little baby who is grasping that orange block. That orange block, it's showing us the crude pincher grass. As for head control, and rolling over and sitting, those are all gross motor skills. So again, those bigger motor skills. And you can see here, we have in picture A, we have a newborn who has complete head lag. And that'll happen until about 1 month typically. Now some babies, just like anything, some babies are born and are able to support their neck fully, and some have this head lag. Picture B is about 2 months of age, and that's partial head lag. And picture C is about 4 months of age, and you can see that there's virtually no head lag in that baby. And this is also head control. It's just the baby is still the 1 month, 4 months, or this picture actually is 1 month, 4 months, and then 6 months. And this has to do with the baby being able to lift its head up. This is kind of a funny little reflex. It's called the parachute reflex. And this is to prevent a baby from getting harmed if they fall. So you can see even super early on, babies are going to put their arms out to prevent themselves from falling on their head, because again, that head is so important, right? That vital brain, we've got to protect it. And here again, we just have the stages of sitting. So you can see the progression where they're able to somewhat sit in that in the position, and then they're able to lift up a little bit more, and then they progress fully to sitting on their own. And the gross motor development is going to develop just like anything else. It develops in that subcaudal direction. So we're gonna start with being able to lift up that head. Then we're gonna be able to crawl, which is lifting up the trunk and the chest. And then we're gonna be able to creep, which is using those arms. And then we're gonna be able to walk. And you can see the ages that are associated. Now these again are generalizations, and every baby is gonna be just a little bit different. Some might develop earlier, and some might develop a little bit later, and that's okay. It's just, again, a visual representation of the various stages of locomotion. As for the psychosocial development, And we're looking again for that sense of trust. So this is Erickson's first stage that we're going to be discussing when we're discussing those infants. This is all determined by the quality of the interaction between the infant and the caregiver. So if that interaction is not a quality interaction, that baby is going to develop mistrust instead of trust. And certain things can contribute to that if the baby's needs aren't met, or if they're met too soon. So if we have a parent who always feeds the baby before they're even remotely hungry, or makes the baby sleep more than they should, those things are all going to contribute to mistrust. So we want the baby to be able to communicate to us that, hey, I'm getting hungry. But what that looks like for an infant is very different than what that looks like for, let's say, even a toddler who's able to either sign or communicate to us outwardly that they're hungry. With an infant, we might have a subtle sign as a fist grasp. If their fists are clenched, that means they're starting to get hungry. Crying is a late sign of hunger. So the parents need to be very aware of what their infant has going on so that they're able to adequately respond to the needs that that baby's communicating to them. We want them to feel comforted. We want to provide stimulation. We want to make sure that there's that interaction. When we get to a little bit older, babies start being a part of their environment more, like grasping and even biting. Now, biting might be a result of teething. They might feel like they need to clamp down on something. It might just be an exploratory sense that they're utilizing. They might like the reaction they get. I know breastfeeding moms are always a little bit scared of that stage because it can hurt to have a baby bite while they're nursing. The best thing is just to make it an undesired action. So actually smothering the baby into the breast, not yelling, not screaming, but smothering the baby into the breast for 5 seconds tops is the best way to deter that action, because it makes the baby realize that that's an undesired effect to the biting, if that makes sense. So we're going to discuss the cognitive development also, and again, we're only discussing these things through that first year of life. So for Piaget, we're looking at the sensorimotor phase. And remember when we talked about this in the last lecture, this has to do with the babies utilizing their environment and interacting with it. So we're going to see sucking and rooting of the reflexes, that grasping reflex. In ages 1 to 4 months, those circulatory reactions have to do with deliberate actions and the accommodation that occurs. And then the secondary is more intense. So instead of just grasping something, the babies are going to grasp and shake it to make that rattling noise. And then they like the rattling noise. So they associate the grasping and the shaking with the rattling noise. So then they're going to do that just to hear the noise as opposed to just grasping something or just shaking something. So we have these progressive reactions and accommodations to the stimulation in the environment. When we look at imitation, remember, imitation is how the babies and these infants are able to process their environment and figure out what they should be doing. They're going to watch their parents, they're going to watch their siblings, they're going to watch their caregivers to see how they react to certain things, and they're going to do that. Even as young as just 6 months old, you can see a baby imitate its mother's reaction to even a potential person. So be careful if you really don't like that in-law, because if you respond poorly to that in-law, that baby's going to respond poorly to them as well. When we're looking at play and affect, so imitation, play, and affect are all just the processes of human behavior that are developing at this stage. Play is going to be something that the infants use to explore their environment, to develop those skills. It's playing with blocks and manipulating sand and all sorts of other sensory-motor type activities. And the affect is going to develop, whether we have a happy response or whether we have a negative response. Those are all going to be developing during this time. As for the second schemas, it's transitional and it's adding on to things. So again, it's similar to that rattle example that I gave you earlier, to where we're not only going to grasp the rattle, but we're going to shake the rattle to make that noise. At this time, we're also learning about separation. So the infants are starting to separate themselves from the environment and from their mother. So for the first few months, that baby doesn't understand that they're different from the mom. They don't have the awareness that they are their own separate being. So around this time, they start to realize that, or around between 6 and 8 months, or 4 to 8 months, they start to realize that they're a separate being, which can produce some significant anxiety because they're not confident that caregiver, the mom, is always going to come back to them, right? So we see some of that separation anxiety. We're also going to start to see the object permanence, where they start to understand around 9 or so months that objects, just because they can't see it, doesn't mean it's not there. And this does help a little bit with that separation anxiety, but it's different when it's the caregiver that they're being separated from. But we can see, I think the next, there we go. So you can see this is a baby who's searching for something that was hidden. The baby watched them hide the object, and then she went and found it. So that's an example of that object permanence. And they're also able to start to recognize and utilize symbols, which is mental representation at this time. Sorry, a little shaky. So the concept of body image develops really soon, really early, but it doesn't start with the way we think of body image now. So what we're looking at, or what this type of projection of body image as an infant looks like, is that they learn really on that the mouth is a source of pleasure. For them, sucking and eating is key, right? So they're able to suck. That sucking motion is incredibly comforting to them. And remember in that newborn lecture, we talked about how sucking and sucrose together are going to release endorphins, which is going to essentially provide like an opioid level of pain control for that baby, which is amazing. So the sucking is very comforting for those newborns. They also get their food from that. It's a way to attach with the mom, to connect with her. And even if it's a bottle-fed baby, that's a time that that mom or dad or caregiver is holding and snuggling the baby, and they still have all of that pleasure from the sucking. They also see their hands and feet as objects of play. So it's something that they can play with. I think most people's favorite pictures of infants have to do with them playing with their toes. They hold onto their feet, or they're sucking their toes. That's always such a cute little thing. And it's because they see those as objects of play. And then we're also going to see them realize that when they smile, they get a reaction out of other people. And what a fun reaction that is, because they smile and it just lights up everybody around them, which is awesome. So a picture of the girl searching for the toy. And then here we have a baby playing with herself in the mirror. She's just enjoying her own image in the mirror, which babies love mirrors. They see that smiling baby and they want to interact with it. As for social development, we talked a little bit about the attachment and the separation anxiety, and we're going to see babies start to attach and bond with their parents and their family members. Again, that separation anxiety starts to to be shown around between 4 and 8 months, depending on the baby. And that's again because they realize that they're separate. They're not the same with their parent. They're different. So they don't realize that mom's always going to come back. They have to learn that. And they also have to progress to that next stage of the object permanence to be able to understand that even though mom's not right there where they can see her, that she is around somewhere. And it's easier when parents are just moving out of the room as opposed to leaving a child at daycare. Those are going to be two very different scenarios and interpreted very different by the baby. The stranger fear also develops around that same time, between 6 and 8 months. And this is when the baby starts to be able to differentiate between familiar and unfamiliar. So the baby is able to tell, hey, I know this person, uh-oh, I don't know that person. And they like the familiar, so they start to show fear of the people that they don't know. This can be kind of hard for, say, grandparents who live a distance away and don't see the newborn on a regular basis, because that baby's going to have to get to know them every single time they come to visit. There's an adjustment period. So there's an education piece for new parents that if they have grandparents who live far away, just to be aware that the baby's not going to be super excited to see them every single time they come to see them once they get just a little bit older. And for language development, we've discussed this a couple different times, but remember, crying is their primary way to communicate. Babies cry a lot, and your ATI book lays it out really nicely. It gives you like the number of hours each time that babies cry. By 9 to 10 months, babies understand the word no. Remember, we talked about this last time as well, that babies and children in general are able to understand more than they're able to communicate out. So we need to be careful about what we're talking about in front of children, one. And two, they do understand no around 9 to 10 months. And by 1 year, the baby should have about 3 to 5 words. No is typically their first word because it's what they hear the most, and they're really good at saying it. It's an easy word to form. But by about 1 year, they'll have 3 to 5 words. And for play, we're going to see that progression, that solitary play. They have a short attention span, and they want to be stimulated with their senses. They want their senses to be stimulated. They want to do that tactile play. So this is an example of the stranger anxiety. So you can see that this baby is grasping onto dad's hand and kind of pushing the provider away while she's crying. Temperament. So we talked a lot about temperament in the last lecture, so we won't touch on it all too much in this one. Just that, keep in mind, we want to educate our parents that there are different temperaments of the children, and that it does not, it's not because of their parenting. It's not because of them that the baby's crying all the time. If they have a difficult baby, that baby's going to be irritable and crying. So we want to just make sure that we're effectively communicating those things to the parents. And there are ways to calm down difficult children and to help them be more secure in their environment. So we can give them some of those tools too. And you can see there's a questionnaire that lets us kind of determine whether there is a difficult child present, and that way we can distinguish how to provide our education. Do we need to provide our education around parenting skills, or do we need to provide our education around, well, you have a difficult child and you're going to kind of have to bear through this for a little bit. So when we are looking at some of these things that parents are feeling, and this is going to be from the parental side, because these are normal progressions for children. Children are going to experience separation anxiety. They're going to experience the stranger fear. And that's okay. But that can be really hard on the parents. And so we want to make sure that they understand that these are normal reactions to children. And it doesn't mean that they hate this person over here because they won't go sit with them. All it means is that they don't know them and that this is how they're communicating that they don't know them. Sorry, I have to move for a second. So we, again, it's all around education. We want to make sure parents aren't feeling guilty about the separation anxiety and the stranger fear. I mean, I've had my heart wrenched out leaving my children at daycare when they're just so distraught to call the daycare 3 minutes later and they're giggling and playing on the carpet with everybody else. We've also have a difficult child, as I've mentioned, who did not transition so well, which is still incredibly challenging as a parent to deal with that and to cope with the guilt that is associated with leaving that child. But in the society, we've established that both parents work. You know, we have about 40 to, in the last 40 years, that's what I wanted to say, was that we've had a shift in the last 40 years where we used to have one parent stay at home and take care of the children and the other parent would work. And now we don't have as much of that. So this is a reality for most people to be dealing with this. So how do we set limits and discipline an infant? And what do we do that's effective? The most effective thing is to set those limits so they know. Remember, children, even infants, they want guidelines. They want to know what they can do and what they can't do. And they're going to respond better to a structured environment most of the time. So the best way to discipline an infant is a timeout, just a removal from the situation that they're in so that they can reset. And not being able to see the caregiver is actually really effective. We shouldn't do more than a minute of timeout for these infants, but just removing them from the situation is going to be the most effective to make them reset and think, oh, maybe I should have done that. We want to provide an undesirable effect to what their action was. So remember that sucking produces pleasure within the body, right? And it releases endorphins to suck. So a lot of babies revert to some thumb sucking and the use of a pacifier. This is called non-nutritive sucking, and that's okay. What we want to be careful with is providing the pacifier too early. So there's what would be called nipple preference. It's much easier to suck on a pacifier than it is to effectively suck on mom's nipple. So we want to make sure that those babies are able to learn to breastfeed early on for the breastfeeding moms, and that they don't have the nipple preference with that pacifier nipple, which is just easier to suck on. So if possible, we want to wait a week, if not two, to provide a pacifier. And we can just educate people on that. They're going to make their own decisions. A lot of people stick a pacifier in the mouth in the hospital and breastfeed fine for 3 years. But there are those babies who are going to have a difficult time choosing the breast nipple once they've had that synthetic nipple. And the thumb sucking and the pacifier can be great for those difficult babies because it can help them learn to self-soothe, and it can give them something that they can utilize. One is not better than the other from a health perspective. So some parents say, well, I want to give the pacifier because I can take it away. Some say I want to have the thumb, so they always have it. It's, go with what the child would like. From a teething perspective, we're going to start to see teeth somewhere between 6 and 8 months. And again, this can vary, but what we will see is around 6 to 8 teeth by 1 year. So we'll see that progression. Some babies are really bothered by the teething process. They get a fever, they're really irritable, they get a rash. And some babies, you don't even realize that until a tooth pops out, you're like, look, the baby was teething. So parents can be advised to use like acetaminophen or an ibuprofen if their baby spikes a fever or are irritable. There's all sorts of gels and stuff that they can put on the gums. We can freeze a wet washcloth for the babies to chew on, or freeze a teething ring, which is usually like a plastic or silicone ring with some water in it. We can give the babies like a piece of frozen fruit in a mesh or silicone sleeve that they can chew on. So those are all very comforting to those teeth. So when we're looking at the optimum nutrition for our infants, we're gonna always educate that human milk is the best for those infants for the first 6 months of life. Now, that's not always possible, and it's not always preference, and we're never going to make anybody feel guilty about not choosing to breastfeed or not being able to breastfeed. We're just going to educate them that this is the best nutritional option at this time. We also want to offer vitamin D for these infants because vitamin D it doesn't readily cross the breast milk. Now, I'm going to tell you now, my personal take on that is take the kid out into the sunlight for 5 minutes each day. But the reason why the American Academy of Pediatrics recommends the vitamin D is because they also recommend covering your child head to toe in sunscreen, in which case the vitamin D synthesis does not occur. But it only really takes about 5 minutes in sunlight every day to produce the vitamin D needed. So you can kind of go either way. We should probably educate them to take the vitamin D supplements. About 6 months, between 4 and 6 months, but the recommendation is 6 months. We're going to transition this baby to solid foods. We're going to start with single low allergic foods. So like peas or sweet potatoes. And we want to introduce foods one at a time is the recommendation. And the reason being is because if the baby's going to have a reaction, we know what food they had a reaction to. So if the first food we give them is a combo of 4 different things, we don't know which of those 4 produce the reaction. So if we start with just one, then we're able to determine what is causing the adverse reaction. We can do weaning one of 2 ways. We can have self-directed weaning or directed weaning. So self-directed weaning is that we either nurse or give the bottle to the baby until they're done, until they stop. And it is recommended to stop the bottle when we start solid food and to transition to a sippy cup or a straw. The breast, you can keep breastfeeding as long as you would like. The bottle, the recommendation there has to do with the formation of the palate. So we want to make that recommendation. And with directed weaning, we want to recommend that moms just start spacing out the feedings. Just push them off longer and longer and longer. And eventually there will be less milk supply for the baby and there will be less of a demand. Sleep, everyone's favorite infant subject. So infants, we want them to get about 14 to 15 hours of total sleep. And you can see here it says that they should be able to sleep about 9 to 11 hours at night by 3 to 4 months. I can tell you from experience, it doesn't happen. But they should be able to. So they have the capability, they have the physical capability to do it. It's whether they're mentally able to. If we respond to them by feeding them every single time they make a peep, then they're gonna make a lot of peeps because nursing is fun and it's nice. And even bottle feeding, it's nice. So we need to educate parents that if they want their baby to sleep through the night, we're gonna nurse them when they need to, feed them when they need to be fed, especially in those first few months. We want them feeding them every couple hours. But as they get a little bit older, that 3 or 4 months, they are capable of going those long stretches. So let them, and don't we just don't want parents responding immediately. If the baby elevates to a crying, then by all means, but babies are going to wake up a little bit and make noises. Remember, we talked in the last lecture about the sleep cycle. It's 40 to 50 minutes for those babies. So every 40 to 50 minutes, they're starting a new sleep cycle, which means they might make some noises and move around a bit every 40 to 50 minutes. But we don't want mom feeding that baby every 40 to 50 minutes if she wants to get those 9 to 11 hours of sleep, okay? Napping, kids will around 1 give up that second nap that they're taking. So they'll start to nap just about once a day instead of taking the 2 naps. We talked about this a little bit in the last lecture as well, whereas infants are naturally very active and we need to allow for it, but not necessarily promote it. So we don't need to put our babies in swings and walkers and bouncies and things like that, because that can be more restrictive than anything else. So for dental health, we want to make sure that parents are brushing their baby's teeth. Even the gums, we want to be cleaning the gums with just a wet washcloth early on. And when the teeth erupt, they need to be brushing them. Just because they're babies doesn't mean they don't need to brush their teeth. They still need to be brushing their teeth. You can see here the development of the teeth and when they typically come out or erupt. So when we can see those teeth. So big topic in promoting health is immunizations. And it's somewhat of a controversial topic. However, the CDC and the American Academy of Pediatrics both recommend that immunizations. There's been significant research done on immunizations, and none of it correlates with autism specifically. So from that perspective, we want to make sure that we have adequate education for our patients. We also want to make sure that we are approaching this with respect for the individual, and we want to find out their reasons if they're declining something, just like that vitamin K. So why are you declining it? Are you declining it because you think it's going to cause autism? Are you declining it because you don't want your child to get a shot? Are you declining it because you have a significant health concern? There are reasons that we would not want to give a baby some immunizations. There's products in some of them that babies can, that there might be a history of a reaction. Children who have epilepsy, we're going to be a little bit more conscientious of what type of immunizations we're giving to them, just because it can be triggered. So there are certain contraindications that parents can talk to their healthcare providers about. But our job is just to kind of figure out what's the reasoning behind it, and is it an educated decision or is it just an off-the-cuff decision? This is an example of the immunization schedule that's recommended by the CDC. And this is just another view of that. So some of the routine immunizations you can see here, and they were on the other page as well. And various immunizations are offered during different times. Some are offered as a combination, which is kind of nice for those parents who want to eliminate or minimize, I guess I should say, the number of shots that a baby's getting, because we can give a few different vaccinations all at once. And so we talked about this just a little bit, that there are certain things that we are going to say, well, we're not going to give a vaccine because you have this certain condition and it might produce an adverse effect. If there is an adverse reaction, we want to report it, because they are very closely monitored and researched to determine the cause of what it is, because we want vaccines to be safe. We don't want vaccines to have such a aura of negativity about them. We want to protect our population and make sure that we are eradicating some of these horrific diseases like polio. So we're gonna do as much as we can to make sure that what we are giving these children is safe, because we also don't want to cause any adverse reactions. For each vaccine, there's an information sheet, vaccine information statement, which you probably have seen even if you don't have children because you receive it as well. So when you got your flu shot, you got this information sheet, and it just has a lot of different information about what you're being given, what's in it, what the purpose is, who shouldn't receive it, all sorts of stuff. So if you still have your flu shot one, go take a look at it and see what information is contained in it. Okay, another big topic here, safety. So what is our role in helping parents provide a safe environment for their children? We are back to education. So we are going to educate our parents, especially in the postpartum time, about the importance of the car seat and making sure it's an up-to-date car seat, it's not expired, and it's the appropriate car seat for the size of their baby. We're going to talk to them about, driving safely and always having the infant rear facing. And we're going to talk to them about just the safety in their home as well. So we want to make sure, and I think this is on that pediatrician check-in form that I was talking about in the last lecture about, do you have chemicals out where the baby could reach them? Do you have, is your furniture secured? Because there have been an unfortunate number of deaths from babies grabbing onto a TV and pulling them down. Those TVs are heavy, those armors are heavy. Even that little IKEA furniture can produce significant harm from falling on a child. So we want to educate our parents about all of the things they need to do to kind of child-proof their home. Luckily, a lot of these things are suggested for the home regardless because it provides a safe environment for everybody, not just that baby. But they have to remember, with a baby in the house, they've got somebody crawling around who has no idea what they're touching, who wants to touch and feel and put everything in their mouth. So that's a key point of education. And here's an example of a rear-facing car seat. One of the other nursing interventions that occurs in the postpartum time is for little babies. Everywhere is a little bit different, and I mentioned this in the newborn lecture as well, but I think it's 2,500 grams or below is kind of the standard, or less than 36 weeks. We're going to do a car seat challenge test where we put the newborn in the car seat for an hour and we watch their O2 sats and make sure they're breathing effectively, because the neck could end up like this, in which case they're not going to be able to effectively pass air. So we're going to test that out. Colic. So we have that difficult temperament of a child, and sometimes we get to add colic to that. Or we can just have a colicky baby. This occurs in, as you can see, 15 to 40% of all infants. That's quite the range, isn't it? So it's such a large range because it's really hard to actually diagnose, and it's not all parents bring it to the attention of the primary caregivers who would be reporting this data. So some of the things that we can do is just educate first we're going to figure out if there is an actual cause. So is there a GI issue present that we need to fix? Or is it just that this is a fussy baby? There could be reflux present, and some of the things we're going to do is ask questions regarding the feedings. We want to know what time the baby feeds. We want to know what the baby's activity is before and after feeding. We want to know what the mom's activity is before and after feeding. We want to know the mom's diet, and if the baby's eating anything else. We're going to want to know the sleep cycles and all sorts of different things, and that allows us to kind of pinpoint where the problem is and determine if it's something that we can fix. Sometimes we can, sometimes we can't. There's all sorts of things that can help. If it's reflux, we can give medications. Some babies have a difficult time breaking down the full proteins that are that they need to when they're given either regular formula or breast milk. And so there are very specialty formulated formulas that are hydrolyzed down to the level of the amino acid. And sometimes switching to that makes all the difference in the world. And that baby's gut is able to handle that to where it wasn't able to handle either something in mom's diet or the size of the proteins or just the proteins in the formula. So here, I just feel for this mom when I see this picture. mostly because that was me for 8 months. But when you have a screaming infant, we're gonna try to calm them down by doing them side lying. We want them side lying. We're gonna sway back and forth, and we're gonna shush them. So shh, 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 and that really helps. And sometimes they'll calm down, and sometimes they won't. Another kind of a special health problem that we might see is failure to thrive. Now, failure to thrive has to do with the baby not putting on weight. So remember at the beginning of this lecture, I said that we determine the growth and whether the baby's doing well by its height, weight, and head circumference. So if the baby's not growing, we're gonna look at failure to thrive. And these babies fall below the 5th percentile on the growth curve. We need to identify what the problem is. Is it that the baby's not absorbing the food it's being given, or is it that the baby's not receiving enough food? So sometimes parents in the lower socioeconomic areas will water down the formula further than it should be because they don't have enough to give the baby. And that's gonna cause major problems for that baby. And we want to give them and hook them up with the resources, because there are so many resources out there for low-income families, especially when it comes to having newborns and making sure those newborns have exactly what they need. You can get diapers and food for mom and food for baby, and I mean, there's tons of fabulous resources out there. So we want to connect them to those. It might just be a knowledge deficit. Do the parents just not know how much to feed? It might be somebody who is stubborn and adamant about breastfeeding, and they're just not producing the milk that they need to produce to adequately sustain this child. That's a really hard conversation to have. But we want to educate those parents that we need this baby to, we can show them on the curve where they should be. And there is a little bit of a different curve for breastfeeding babies than there is for formula-fed babies, because they just don't gain weight quite as rapidly. However, we still need them to be at a certain weight for certain times. And if they're not, they're going to be considered failure to thrive. This is just demonstrating that it's important for nurses to establish a good relationship with any family who's having problems, either colicky babies or failure to thrive babies, or babies who have other special health problems. We just want to make sure that we are connecting with those families and we're establishing relationships with them so that we become a trusted source of information for them. So I'm going to show you the picture on this because the picture says more than the description, but positional plagiocephaly. So we've started to see more of this because of the Back to Sleep campaign, which I'm sure you all have heard about. So Back to Sleep is something that we want to educate our families on so that they put their babies on their backs to sleep as opposed to on their bellies. Because when they're on their bellies, we can increase the risk of SIDS. When they're on their backs, the risk of SIDS is lowered significantly. However, when we started that, we started to see a lot more misformed heads. And remember, we've seen how those babies, and some of you have had the opportunity to feel it already, but those the skull bones aren't approximated, they're not fused when those babies are born. So when they're born, they're actually usually overlapping, but they grow and they fuse. So we want to make sure that the baby's head is appropriately formed when those grow and fuse. And so some of the things that we can do is recommend a lot of tummy time when the baby is awake, and recommend not too much time in the car seat and stuff like that. But if it is a problem that's diagnosed, then you can see here the helmet that the children can wear, and they wear it 23 hours a day. So they wear it a lot. And that's just to keep their head in the appropriate shape. And then there's no real pathophysiological problems that go with this. It just has to do with the shape of the baby's head. I briefly mentioned SIDS and the Back to Sleep initiative, that we want all of our newborns to sleep on their back, not on their tummies. SIDS is sudden infant death syndrome. And with SIDS, we really don't have a specific cause. We know there's certain risk factors, so somebody who smokes in the home, if there is secondhand smoke, that those babies are at an increased risk. Sleeping on the tummy, those babies are at an increased risk. And inappropriate co-sleeping, those babies are at an increased risk of SIDS as well. And when I say inappropriate, the baby should be in the room at the newborn stage. That's the recommended to prevent SIDS, but it shouldn't be in the bed. And it's hard to communicate that to parents because they want to snuggle with their baby. And so there are specific situations to where co-sleeping is adequate. However, it's kind of like the whole drinking while you're pregnant. One beer or one glass of wine is not going to harm the baby. However, moderation is key, and we cannot assume that people are going to moderate. So we just say no, you cannot drink during pregnancy. It's kind of the same thing with co-sleeping. If the baby is between mom and, say, the wall or a co-sleeper or something else, then the mom has a natural instinct to not roll over her baby, assuming she is not otherwise inhibited. So if she's had one sip of alcohol, has taken any sort of painkillers or anything like that, then that is not an appropriate situation. And baby should not be co-sleeping next to dad. He does not have that same instinct. So those things are hard to educate people on. And so we just kind of say a hard no. So there's fabulous things, though, that parents can get, which but right up against the bed, and so the baby's right there with them, but they have their own sleeping space to keep those babies safe. If the infant has a sibling who has died of SIDS, then they're at an increased risk as well. So there is a little bit of a genetic component, but it's one of those things that we just don't know too much about. When autopsies are done, often there's pulmonary edema and found in those babies. It is a respiratory issue most of the time. There's something also called an apparent life-threatening event, and this is kind of a near-miss SIDS. So what happens here is that the parent recognizes that there's something wrong, and they're able to stop it before it progresses all the way. And typically this happens during sleep, and a baby starts to turn blue or has significant pallor, has a period of apnea or hypotonia, and those periods are in these situations are luckily observed by the caregiver and are able to be intervened upon, in which case the baby doesn't have a lasting effect. So it can be very scary, and with both this and SIDS, we're going to want to do significant follow-up. With SIDS, we want to make sure that we are communicating in a therapeutic manner. We're not blaming the parents. We don't want to come back at them and say, well, didn't you notice the baby wasn't crying? Or didn't you notice your baby turning blue? Those are not therapeutic statements to be making, and this parent just lost their newborn baby. We need to be very cognizant of how we're communicating with them. We're gonna, with these ALTEs, we're gonna set the baby up with monitoring. So you can see here, we're gonna be able to monitor the baby's breathing and heart rate with this monitor. And that gives not only peace of mind to the parent, but it's also gonna identify any other adverse effect that we might see, or adverse event, sorry. So we might be able to determine what the cause is. Another common problem with babies is diaper dermatitis. Now this is more severe than just diaper rash. Oh, I thought there was a picture there, sorry. There's great pictures of it in your book. It's more severe than just diaper rash. And the cause is mostly has to do with prolonged exposure to the urine, the feces. It might be something the baby ate that is causing the pH of the urine and the composition of the urine to change. And so the skin is reacting significantly to it. So we want to keep that in mind too. But again, we're back to education. So we're going to give the parents a topical cream to use. However, we want to make sure that we're educating them to perform frequent diaper changes to kind of let that baby air out every once in a while. And cradle cap is very common. Parents don't use shampoo a lot on newborns' heads, which is okay, but this is how cradle cap forms, because it's the oil, it's the sebaceous glands start to produce the oil, and then it gets kind of, the skin cells that are sloughing off get stuck with the oil, and then we get the cradle cap. So we want to recommend that parents utilize shampoo, and if there is cradle cap that's formed, they can utilize coconut oil, or like a dandruff shampoo is recommended, or coconut oil on the cradle cap, and then a fine-tooth comb, and it comes right off. Okay, so now we have a question. Latasha is a breastfed infant being seen in the clinic for her 6-month checkup. Her mother tells the nurse that Latasha recently began to suck her thumb. Which of the following is the best nursing intervention? So we're going to reassure the mom, right, that some thumb sucking is normal at this age. It's okay to suck the thumb, and it's up to the mom whether she wants to let it continue or not. If you have any questions, please reach out to me via text or email, or come see me in office hours after class. I will see you soon.